Well, good afternoon, everybody. Welcome. This is Barry Sarvet here. I'm the statewide medical director for MCPAP, and I wanted to welcome everybody here and back, if you've been here before, to our Clinical Conversations program. As you may know, our program takes place on the fourth Tuesday of every month. And this session today, we're really excited about. It's going to be focused on the mental health needs of transgender youth. So before we get started, and before I introduce the speakers, I just want to go over a few housekeeping issues. The session will be recorded and is going to also be available on the MCPAP website at www.mcpap.com. So feel free to let your colleagues know if they weren't able to make it, that they can watch it later. The copy of the PowerPoint slides will also be available on the MCPAP website under the Tools and Resources page. Our presenters will stop for questions, or I'll actually interrupt them for questions at times during the interview. But we will also hold questions, some of the questions for the end. So the way that I do it is just feel free to type questions in the chat as you think of them, or in the question section. And if they're if it seems comfortable to insert them into the discourse, then I'll interrupt them, and otherwise we'll sort of save them for the end. At the end of the presentation, also please try to take a moment just to fill out our survey, just so that we can have your feedback for future presentations. So let me go ahead and introduce our speakers. Our speakers are from Bay State Medical Center at the Bay State Children's Hospital, and they all work together in our pediatric gender clinic program. So we have a really nice multidisciplinary panel for our presentation this morning. So the first speaker will be Dr. Shelby Hivanen. She is a pediatric psychologist, and she attended the Wright Institute for her doctoral degree. She also did her internship at the Spokane Mental Health Clinic, and she did a postdoc at UC Davis. But she is one of our clinical pediatric psychologists at Bay State, and she's an assistant professor of psychiatry at the UMass Chan Medical School. Another of our three speakers is Dr. Peter Thunfors. Peter is the clinical supervisor of our child behavioral health program at Bay State Medical Center. He's an assistant professor of psychiatry at the University of Massachusetts Medical School. Or actually, we're supposed to call it the UMass Chan Medical School. And he attended the University of Virginia for his doctoral degree, and did his internship at Temple Hospital. And last but not least is Dr. Michelle Gortkowski, who is a pediatric endocrinologist at UMass Chan Bay State at the Children's Hospital here. She attended Penn State for medical school. And so I think I'm going to hand it off to Shelby, who's going to be the first speaker on our panel.
Thank you, Dr. Sarvet. I'm really pleased to be part of this group today, presenting on gender health and the evolution of gender identity development, and also talking a little bit about the work we do at our clinic. So I will be taking you through some overview of gender identity development and talking a little bit about changing norms and cultural acceptance in the United States specifically. And I'm sure we've all maybe noticed in our clinical work that there are more and more people coming into our offices who are describing themselves as someplace off the binary gender spectrum, and we'll talk more about what that means. All right, I have no financial relationships to disclose or conflicts of interest to resolve today. So we're going to start off with talking about gender messages from society. And I think it's important to recognize that we start receiving gender messages from the time we are born, and in fact, even before children come into the world, usually the first question asked is it a boy or a girl? And then plans start getting underway for color schemes and baby registries. Furthermore, there can be a really strong attachment to what it means to be the parent of a boy or a girl, dreams of what that relationship might look like, and societal views on gender start permeating nearly every important aspect of human life. So that includes things such as education and career, leisure activities, finances, relationships, and more. For me personally, I am a parent of two children. A boy and a girl is how they came into the world. And we really strove to not have strong gender messages. We waited to find out the sex of our children until they were born and tried to keep a more gender neutral kind of environment for them so they could grow up to be who they chose to be. However, it was evident early on that those messages start coming in from the outside. And just as they're unique individuals, we certainly saw them as a boy and a girl. And I will just mention, my work here at the Gender Health Clinic took a deeper level for me recently when my elder of the two children, who's 13, let us know that they were identifying as non-binary. And it really made me think beyond the work I do clinically and from my assessment role in this clinic, what that means and just the nuances of what gender means and as it evolves in our world today. So to start off, people often use the term sex and gender interchangeably. And it's important to recognize that although they are correlated, they are not the same thing. So sex is the term we use. It's assigned at birth. It's based on a baby's genitals, essentially. Whereas gender is presumed based on that child's assigned sex. And in most parts of the world, sex is either male or female. There are some third options in some states and other parts of the world, but generally we're looking at those two options, and then those are the two gender choices that generally get put forward. For many people, this doesn't pose any issue because their assigned gender matches their assigned sex and the society's expectations of those terms. However, for some people, this can cause some confusion and distress when their gender identity does not match what they were assigned. Especially as they're starting to form their sense of self and recognize something isn't feeling right. So when we think about gender, beginning with the assignment of our sex, it really doesn't end there. A person's gender is a complex interrelationship between three dimensions: body, identity, and social gender. When we're talking about body, we're referencing our physical body, our experience of our own body, how society genders bodies, and how others interact with us based on our physical appearance or our assigned sex. In talking about identity, we're using this name to convey our gender-based on our deeply held internal sense of self. So this can range from binary, male or female, to non-binary, which is also sometimes called genderqueer or gender fluid, to ungendered, agender, or genderless. A person's gender identity can correspond to or differ from the sex they were assigned at birth. And then in terms of the social sphere, this is how we present our gender in the world and how individuals, society, culture, and community perceive, interact with, and try to shape our gender. So social gender includes gender roles and expectations, as well as societal pressures to conform to cultural gender norms. Returning to the term body, so sex exists across a continuum of possibilities. And Dr. Gordakowski will talk more about this, but just briefly, research in neurology, endocrinology, and cellular biology shows a much broader biological basis for gender experience than just our reproductive functions. So we know that more than the X and Y chromosome are involved, and there are, some studies say, at least 30 genes involved in sex development. How this relates to gender are questions yet to be determined, but it isn't as simple as we might think. Gender identity is an inherent aspect of a person's makeup, and it can be recognized at an early age. In fact, according to the American Academy of Pediatrics, by age 4, most children have a stable sense of their gender identity. There's also down at the bottom, you'll see on this slide, a 2015 US transgender survey. So a survey of people who identified as transgender. 60% as adults reported recognizing a difference between their gender identity and assigned sex by age 10, and 96% by early adulthood. Naming one's gender can be a complex and evolving reality. It may take a person time to discover or create the language that best communicates their internal experience. So typically we think about gender in the binary, either male or female. However, as time evolves, we're having a lot more terms come into play. So there's male or female, which can be cis or trans. Cis is when it matches your assigned sex at birth. There's also a sphere of agender or genderless, genderqueer or non-binary, and then more and more terms that fall between these all. However, throughout human history, we know that many societies have seen and continue to see gender as a spectrum and not limited to just these two possibilities. And youth and young adults today, we're finding are much less bound by the gender binary and are establishing a growing set of vocabulary and terms for what their gender experience means. There are many visual representations out there for what this gender spectrum might look like. This is another that I had found called the gender pyramid. So the bottom is agender or genderless, and then sort of that intensity of a feeling of gender goes up to those 3 points: female, male, or other / non-binary. When talking about gender, an essential aspect is a feeling of congruence, a personal journey to finding a sense of harmony in our gender. This relies on the acceptance and support of a person's immediate community as well as society at large. This feeling of harmony means experiencing comfort in our body as it relates to our gender, naming of our gender that adequately corresponds with our internal sense of who we are, expressing ourselves through clothing, mannerisms, interests, and activities, and being seen consistently by others as we see ourselves. When we think about gender identity development, it isn't just gender identity, body, and gender expression, but all the other parts that make us individuals: ethnicity, race, class, faith, community, geography. So moving a little bit into a few studies that have come out. So there's research expanding in the last decade related to transgender and gender diverse communities. This is a poll, the Harris poll from 2017, that looked at adults age 18 and older. And you can see across these columns on the far left, it's the millennial group, 18 to 34. 88% identified as cisgender. Again, their gender reflected their assigned sex at birth, whereas 12% actually identified as somewhere on the gender diverse spectrum. And it's notable that just 2% of that used the term transgender, the other 10% used a variety of other terms. So partly with research these days, we're looking to capture the range of language that people might use to reflect their gender experience. In terms of studies of youth, recent studies report that 2 to 9% of US high school age youth identify as transgender or gender diverse. And again, it's worth noting this 2017 study really just used the term transgender. The 9.2% came from a survey of students in Pittsburgh, and they used the more broad term of terminology under that gender diverse kind of category. Across the US, laws are being passed to require some changes in how we view gender at that level. Identification documents, gender options are now often including male, female, or non-binary. As we all know, there's been a lot of discussion about single-user bathrooms to be marked gender neutral or all gender, and push to allow transgender or gender diverse individuals to compete in traditionally female or male sports teams or the military. Upon taking office in January, President Biden issued an executive order on preventing and combating discrimination on the basis of gender identity or sexual orientation, including equal access to the restroom, locker room, school sports, vocation, healthcare, housing, and equal treatment under the law. Just as it's important to separate sex and gender identity, likewise, gender identity and sexual orientation are incorrectly correlated. Gender identity is personal, how we see ourselves, and sexual orientation is about how we relate to others. Likewise, gender expression, how we dress and present ourselves in the world, does not necessarily reflect either gender identity nor sexual orientation. A nice graphic that's often used to talk about all of these areas of gender identity and identity at large falling on spectrums is a gender unicorn, which in itself talks about the uniqueness of each individual and breaks it into gender identity, gender expression, sex assigned at birth, physical and emotional attraction. So in summary, there is a generational divide in how we think about gender, however cultural norms are shifting. Gender diversity has existed throughout history and all over the world. Gender is a fundamental aspect of a person's identity and deeply influences every part of one's life. And finally, individuals who exist outside of restrictive gender norms risk facing disapproval, discrimination, and even violence. Thank you.
Okay, so I think then we move on to my part, if there's no other questions in between. So thank you so much for this opportunity to be here today. My part of this talk is about gender affirming medical care, which could be an entire talk in and of itself. But the goal of this little piece is to try to tie in how the medical care does help with the mental health of our gender diverse youth. So in it, there will be a brief overview, but like I said, it won't be all encompassing in terms of the medical therapies. I also have no financial relationships to disclose or conflicts of interest to resolve. So first, I'd like to start by talking about gender. So from Shelby's part of the talk, hopefully everybody has an appreciation that gender is less like this with binary male and female and more like this, where it can exist, I apologize, on a spectrum and people can identify at different parts of that spectrum throughout their life. As pediatric providers, we are in a very unique position as we are in contact with individuals from infancy all the way up to young adulthood. And so starting this conversation early is really important. And it can start by a number of ways, just having the clinic environment be a safe place and a very inclusive place with gender neutral bathrooms, having intake forms that let and allow individuals to write in their gender identity, not asking, mother and father's names, but asking parents or guardians. So you're not automatically labeling someone as male or female or having a traditional mother and father family. It could also be as displaying pride flags in a clinic, wearing badges that display your pronouns. So making it sort of the normal, being very normal to be able to express who you are and identify as in that space. And that'll be helpful to allow children, whether they're not at a point that they're comfortable telling their parents, but maybe they'd be comfortable disclosing to you as a provider of how they truly feel about themselves. As providers, we are seeing as general pediatricians, seeing kids all throughout the development. And even recently, I have 3-year-old twins, one who was assigned male at birth, one as female. And they were even asked at their 3-year appointment, do you feel like you're a girl or do you feel like you're a boy? So even at that young age, when their gender identity is starting to develop, but they very much know, if they're a girl or a boy, but they're being asked, how do they feel? Do they feel like a girl? Do they feel like a boy? And as they grow, as children become more into adolescence, this is typically a time we might spend a little bit of time with the parents by themselves and youth by themselves, and really making it normal to talk about, how do you view yourself? Do you feel yourself as more masculine or feminine? What do you have preferred pronouns? Do you have a preferred name that's different than what's listed on your chart? So asking those things and making it normal. And that might just start by introducing yourself, or maybe you have a preferred name or preferred pronouns, or making that, displayed on your badge. And so why is all this important? Because we know that transgender and gender diverse youth are at significantly increased risk for violence, substance abuse, depression, and suicide attempts. The 2017 Youth Risk Behavioral Survey shown that about 35% of youth in ages 9 to 12th grade had attempted suicide, and 44% had thought about suicide, which is huge numbers compared to the general population. And so it's really important for families and providers to be aware of this, because research does show that transgender and gender diverse youth who have supportive support from their families have better mental health outcomes. So this can mean less likely to have depression, less likely to have suicide ideation or attempts. We know very well at our hospital that we have quite a number of youth that are admitted for suicide attempts or gestures that have a central cause or related to their sort of gender identity and struggle psychologically related to their gender identity. So this kind of leads into the medical and non-medical interventions. So a lot of what I do in the endocrinology, so I'm both a pediatric and adult endocrinologist. So a lot of my time is spent with medical interventions. However, in our pediatric gender program, we see people in all phases of their gender identity. And some might be very young and just starting to question, and some might be already socially transitioned and they're ready for medical intervention. So it's really a wide range. But in terms of that non-medical intervention that you could help families navigate is, just initially first starting out with the families being comfortable using the preferred names and pronouns. And that might sound simple, but it's really not sometimes. It's really hard for some families, not that they may not necessarily want to be supportive, but they might have a sense of grief or a loss of a son or daughter when they're, who they thought that this individual was is now different than what their preconceived notion was for their child. Or there might be some anger. It's not uncommon that families are sometimes a bit angry, and how is this happening? Is this just a phase? And they question it. So being able to give resources to the family and allowing them that individual child to explore their gender identity. It doesn't mean we have to talk about medical interventions at all, but just letting the family be supportive, using preferred names, letting them express themselves, whether it's by haircuts or clothing or something like that, until they figure out who they are. Some of these non-medical interventions might also include binders or tucking or packing so that their outward physical appearance could match who they identify as internally. And there are a lot of available sources online. I put a link on here to some handouts about binding and tucking 101. That's through the UVM Health Gender Clinic, because as a lot of families want to make sure that the kids are doing it safely. In terms of the medical approach, it is very much a multidisciplinary effort, and everybody requires an individualized approach. I really like this quote from one of the papers from pediatrics. The decision of whether and when to initiate gender-affirming treatment is personal and involves careful considerations of risks, benefits, and other factors unique to each patient and family. So it's not a one-size-fits-all. Not everybody's ready at the same time. Gender evolves over time, so it's not uncommon that someone might have identified as more masculine at some point and maybe more non-binary as they go along and they're figuring things out. So it's important to have a continual reassessment, open discussions with the individual as well as the family. In terms of pre-pubertal management, the interventions mainly are those ones that I had just mentioned, is really providing support to the individual and the family socially and mentally. A lot of transition can happen, without any medical intervention. So, I have a couple patients who identify since a young age. And so even starting at kindergarten, they had changed their name going into the school system and pronouns right from the start and how they dress. And so that social transition or school transition is very important. providing education and resources. And there's no role for gender affirming hormone treatment because prepubertal, they don't have any hormones on board at that point. So it doesn't make sense to block or replace with any hormones since there isn't any hormones there. So earliest that we can start to intervene, and like I said before, this is very individualized, and I will say a majority of the patients that come to our clinic are late or post-pubertal, so they're not, most of the patients are not patients that are presenting very young. But the earliest we can introduce some medical intervention is in early puberty. So this would be Tanner 2. So this is for females assigned female at birth. This would be breast bud development. And for those assigned male at birth, this would be the increase of testicular volume to 4 cc's or greater, which is something usually found on a physical exam by a provider. Usually this is very subtle and not noticed by family members. And why this is important is because for many adolescents, going through puberty, while even for a cisgender individual is very stressful and awkward, could be very unbearable for those whose gender identity does not match the changes that their body is going through. The medications or interventions we use are called GnRH agonists. And these are the same medications that are used in precocious puberty to quote, block or pause puberty. So some people might refer to this as blocker therapy or puberty blockers. And so if you remember, in terms of puberty starts when the GnRH is pulsatile, and you can see that back from the little picture here, and that will lead to the rise in the LH and FSH, and then a subsequent increase in the estradiol or testosterone. So if we give a GnRH agonist, it blocks this pulsatility, and therefore it blocks this feedback loop, and so the puberty does not progress. And pubertal suppression is considered a reversible intervention that could allow an individual more time for social transition and self-exploration before potentially deciding to move forward with gender-affirming hormone therapies like estrogen or testosterone. It can also help with physical transition later. So if it is an individual who presents early puberty and they are started on blocker therapy, if they are a trans female, for example, it can help prevent the development of an Adam's apple or sort of a male type jawline or male body fat distribution. And so once they're at a point that they can add estrogen therapy, some of those more difficult physical features might not have developed if they were able to start blocker therapy at an early age. The pictures I have here are from a book, Becoming Nicole. It was came out in 2015. There are numerous books now out about individuals and their journey of transition, but this one I do recommend. And these picture here, so this is Nicole here on the right-hand side, but these two individuals were born identical, assigned male at birth twins, and Nicole knew from a young age that she felt that she was female and a girl, and so it's the journey of her in terms of coming out with her family and starting hormone therapy, and also her struggles at school. It's a very good read. But you can see, just comparing the two, since she did start blocker therapies early, you can see how she has more softer facial features, and you can't, there's no obvious Adam's apple as there is in her twin's brother. So it can help with transition later. Then obviously the next step, if the individual, depending on age, family, goals, which, like I said, are continually readdressed throughout visits, we can add testosterone or estrogen therapy depending on the gender identity of that individual. And I'm not going to go into specifics of testosterone or estrogen therapy, but the overarching goal is to reduce their endogenous sex hormone level and replace with those consistent with the individual's gender identity. It's important to continually review with families, like I had mentioned, what their goals are, and set expectations for what changes may or may not happen when these interventions may be started. We have extensive discussions with the family about reversible and irreversible effects of the therapy, as well as have a discussion with fertility plans, as we know that even though there isn't a specific dose or time, but the longer on testosterone or estrogen at increased doses, it will eventually affect fertility. So even though these are adolescent kids who are probably not thinking about fertility at all, it is a conversation that we do need to have. And one of the main questions is does these endocrine interventions or gender affirming hormone interventions improve the mental health or well-being of the youth? There's a lot of controversy in the literature and blogs and what you read online about, access to gender affirming care and potentially starting youth too early or too young on these things. And that's why I said it's a very individualized approach. But there is data that gender affirming endocrine intervention does improve the mental health and well-being of transgender youth. The excerpt from the top article that was published last year was preliminary results, but it looked at, I think, 3 or 4 years of data where they had their participants take different depression and suicide scales each time they came in, and it's every 6-month interval. And they did find that their depression scores went down, their number of suicide ideations went down, and their overall quality of life scores had improved. Similarly, with the one on the bottom that just came out earlier this year, this was a systematic review. This includes both adult and 3 adolescent papers, but again, similar results in terms of improved quality of life and improved mental health. So it is really important that we have the tools and have the knowledge to be able to provide care for these gender diverse youth, and when appropriate, be able to prescribe potentially puberty blockers and then eventually testosterone or estrogen therapy. But I think the main thing is that it's a multidisciplinary effort, and it's not always easy. And this is why we rely so much on our colleagues, Shelby and Peter, to help us through this process, because not everybody is in the same place at the same time. And there's a lot of psychosocial factors that go into that. So hopefully that's a segue into Peter's talk, who's going to talk about all the different scoring systems and sort of gender evaluation that we do in our program.
Thank you so much, Michelle. I am excited to be here, and my part of the presentation today is going to focus on the assessment process for gender dysphoria. And I have to admit, it was a bit challenging to try to present this topic in a condensed way, so I'm going to try to accomplish that by having some information-dense slides that folks can look at after the presentation if they're interested. And I'll try to go through some of this content here together with you all at a pretty brisk pace. I also don't have any conflicts to disclose today. The first 2 slides here just include the DSM-5 diagnoses for gender dysphoria. And I'm not going to go into these in great depth, but just wanted to highlight a few things. There are 2 separate diagnoses in the DSM-5. One is for gender dysphoria in children, and the other is for gender dysphoria in adolescents and adults. And the DSM-5 defines gender dysphoria as a marked incongruence between the experienced gender and affirmed gender. That needs to be present for at least 6 months. And for children, in order to meet criteria for the diagnosis, they need to exhibit 6 symptoms, whereas for the adolescent and adult diagnosis, the requirement is only 2 symptoms. And as with most of the DSM-5 diagnoses, there needs to be an association with significant distress or impairment in important areas of functioning. And to connect to Shelby's presentation, where she was discussing the diversity of gender identity, I also wanted to emphasize in my experience in our clinic that I've also seen a lot of individual variability in, more specifically with experiences and expression of gender dysphoria, including the timeline developmentally for which people's experiences of gender dysphoria emerge. I also wanted to make sure today to mention the WPATH standards of care. So WPATH is the World Professional Association for Transgender Health. And I would strongly recommend familiarizing yourself with those if you are going to be working with trans youth in your practice. Relevant to my portion of the discussion today, they do have some guidelines related to assessment, which I won't discuss in detail, but one part of those guidelines that I found particularly helpful was using the discussion of the possibilities and limitations of the medical transition options. Of course, to ensure informed consent for young people who are going to be pursuing those options, but it's also been really helpful for an assessment perspective to make sure that those sorts of changes that they're pursuing would be so that the fit for their needs and the types of changes that they would most want to see. Just to sort of reiterate this point with the assessment process, I always like to start that off by clarifying pronouns and preferred name. And I found that that's been really helpful to do because sometimes there's a lag time between when one of our endocrinologists, like Michelle, might refer a child to see us, and during the span of a few months, there may be some evolution in their identity and those preferences. And especially trying to convey a tone of affirmation in particular and kindness at these meetings. I think sometimes kids can come in and they can feel some anxiety about the process. And there's this strong motivation and this eager anticipation to get started with their medical transition options. And I think taking that affirmative approach can, I think, be reassuring for some of those kids. So just to, I think really to emphasize in my portion of our meeting today, just some tips and ideas for how to gather a gender history when you're working with young people who are gender diverse or identifying as trans. I usually start these appointments by easing into the conversation by asking people about their plans for the future, their hopes and dreams related to transitioning. It sort of helps to sort of establish the reason why we're meeting is that this is part of the process of them pursuing those medical transition options. And I'll ask specific questions related to what body parts do they want, what do they want removed or changed, what are they doing currently to try to address their dysphoria with different areas of their body. And as Michelle had mentioned before, for those who are going to be doing gender-affirming hormone therapy, that's considered a partially irreversible intervention. So I always try to make sure to go over the components of that are partially irreversible to make sure that there's sort of comfort in the possibility of those being irreversible. Asking about early childhood memories is been really helpful and an interesting process. I would emphasize that gender dysphoria is not necessarily going to be present in childhood. I think a fair amount of the kids that we see didn't really have their gender dysphoria emerge until the onset of puberty, and have certainly worked with a few people whose gender dysphoria sort of emerged post-puberty as well. And for this portion of the assessment, just sort of checking in, was there any indications or any experiences of gender dysphoria early in childhood? Was there discomfort with their bodies at a younger age? Was there preference for play or activities or playmates of another gender? And it's some of the responses that I've heard from kids when we're talking about the early childhood portion of their experience. Often kids have said to me something along the lines of, I didn't have words for it at the time, that they knew that something felt different about their experience, but they just didn't have almost the sort of concept of that it could be possible to be of another gender. They hadn't heard the terminology around transgender or gender diversity at that point. A few kids have also sort of discussed the process where at first they thought maybe that they were gay and that they were sort of going through a process of questioning their sexuality before coming to a realization that what they were sort of experiencing was more related to gender identity than it was to sexuality. In gathering information about puberty, I do ask specific questions here. So I will ask, what was it like for you when you first started to have your period? How did you feel when your breasts began developing or your voice deepened? How has it been for you when you first began to have erections? To really kind of get a specific sense of what the emotional response was to the various aspects of the pubertal changes. For coming out, I will ask who they've talked to, when they did that, why they chose certain people to communicate with, how they went about that communication. And here trying to get a sense of not just sort of assessing the youth experience of that, but really wanting to get a strong sense of their support system as well. As Michelle noted, that's one of the best predictors for health and psychosocial outcomes. So really trying to make sure that they have adequate support. When assessing for their current relationship with their body, I usually start here with an open-ended question. How do you feel about your body? And then from a more open-ended discussion, transition into more specific questions and asking about different interactions. For example, what's it like for you with showering? How is using the bathroom going? When you see yourself in the mirror, what is that experience like for you? Many of the kids that we see at our clinic have already done a fair bit of social transitioning. So they may be out at school and with their friends and family. They may have made some changes or modifications to their gender expression. So I try to get a sense of how those efforts are going so far, what is working for them, is there anything that's not working for them, and how much has their gender dysphoria been alleviated so far from those social transition changes. I'm going to read this quote on this slide from the American Psychological Association. Transgender children typically, consistently, persistently, and insistently express a cross-gender identity and feel that their gender is different from their assigned sex. And those concepts of consistency, persistence, and insistence is another helpful aspect to be considering in the assessment process. And so consistent would mean the identity is relatively unchanging over time, persistent in the sense that the child is continued with that identity despite potential difficulty, opposition, stigma they may be facing, and that it's been insistent in that it's been unwavering. I don't think we'll have time to discuss some of the questionnaires that we use in depth, but just to briefly describe them so you're aware of them. One is the Utrecht Gender Dysphoria Scale. We use the gender spectrum version. And this comes, and on the slide, you'll see some examples of some items from that. It comes from the Gender Affirmative Lifespan Approach, GALA, that's from the University of Minnesota Medical School. They have a really great set of tools for assessing issues related to gender dysphoria. So they have some that assess for sexual functioning, family environment, body image. So definitely a resource that I also recommend. And then another questionnaire we've been using is the Gender Identity, Gender Dysphoria Questionnaire for Adults and Adolescents. Michelle had spoken about this before, but there is a high prevalence rate of mental health diagnoses in this population. Because of that, we also include assessment instruments related to depression and anxiety, as well as eating disorders. Depression, anxiety, and self-harm, those are 2 to 3 times higher in the transgender population compared to the non-transgender population. We see high rates of eating disorder diagnoses as well as eating disorder behaviors at a subclinical level. And there's some complications with the overlap between eating disorders and gender dysphoria. So you may sort of be working with a trans male who may be restricting their dietary intake in order to lose periods. And trans females may be restricting as a way to change their body frame, their physique. But it does seem like research is indicating that relative to younger children and to adults, that adolescents who are gender diverse, transgender, are particularly vulnerable to having comorbid mental health issues. And then Michelle had noted this as well, but because of the increased risk of violence and for sexual assault, I also try to make sure to weave that into the assessment process to get a sense of the young person's sense of safety. I do ask more specific and more detailed questions related to sexual health than I may at a more general intake for psychotherapy in our clinic. And then as part of the assessment process as well, really trying to check in about those protective factors, thinking about family support and positive sense of the future, optimism for the future as being 2 of those factors that we know can contribute to better health and psychosocial outcomes. And finally, I like this description from the WPATH guidelines about how, in discussing, possibility of therapy, where some of the benefit from being in therapy can come from. It said psychotherapy for purposes such as exploring gender identity, role, and expression, addressing the negative impact of gender dysphoria and stigma on mental health, alleviating internalized transphobia, enhancing social and peer support, improving body image, or promoting resilience. And I think in addition to those issues that are more focused specifically on gender identity and gender dysphoria, because of those high prevalence rates of mental health issues, it's important to consider the possibility of referral for psychotherapy to address the comorbid issues as well. All right. Thank you, everyone. I think we have some time left over for questions.
Yes, indeed. We do have time. And thank you very much to you, Peter, and all of our presenters this afternoon. I guess one question I have, just to kind of kick it off, is because we don't have any questions in the chat, and we encourage them. So I hope that some kind of stream in sort of over the next few minutes. But I'm really curious about your thoughts. Just members of the panel, what you think about the role of the pediatrician or the pediatric primary care provider in relation to providing, best practices for youth who are dealing with, gender issues. And, because I think it's really enlightening for us to know, what you guys do as specialists, and just to be aware, of your program and how you sort out the different issues and how you assess, the needs, for these patients. But I think a lot of patients are not going to necessarily get to you. And so we sort of wanted to help primary care providers be able to do as much as they can do in the primary care setting. So I wonder if you can speak to that.
So I guess I'll take this one. So yes, sorry, my voice was not coming out there for a minute. So I think that that's a really good question. And there are definitely places and states, many states where there isn't a gender clinic that is around. And so it is in the hands of the general pediatrician to sort of help manage the gender diverse youth. And there's nothing magical about the medications used. It's not necessarily that they have to come from an endocrinologist. And in fact, once you reach into adulthood, there's many, primary care providers that are more than comfortable and competent in prescribing gender-affirming hormone therapy. So I think it might be a little bit of a culture shift over time, and pediatricians being starting to be more, sorry, my pager was going off, more comfortable with, incorporating this into everyday practice, sort of similar to how, you start taking, sexual histories, and, as kids enter like 10, 11, 12, that we're asking about their gender identity on a more regular basis. And comes down to the environment too. So kids are not going to want to share their gender identity if they're not feeling safe in the environment that they're in. So I think some of it might be creating that environment of inclusivity to start off with, and then just getting into a habit of asking about preferred names and pronouns, which to start off, it seems kind of different. It's not how many of us were taught. I mean, I didn't go to med school that long ago, but I didn't get any training for transgender health as a medical student. And so the way we ask questions and ask about these things feels a little different sometimes and not natural. So just having that practice of asking those questions and asking about everybody's pronouns, no matter if you think there's an issue with gender identity or not, but asking every single person that you see about their preferred name and pronouns, then it becomes sort of normal, and then can create that environment that the children or patients feel safe confiding in the pediatrician about their gender diversity. I know it's not a clear answer, but.
Oh, yeah, no, that's very helpful though. Thank you very much, Michelle. Actually, there's a couple of questions that have come in. One of them is related to this topic, I think, around the primary care provider's role. And so Kate asked if there's a website or a resource you could recommend for pediatricians to find therapists who specialize in working with children and adolescents with gender identity needs.
That's an excellent question. I can say in our clinic, we have a list of our local community therapy resources in Western Mass of providers who do have specialized expertise in working with kids who are gender diverse or trans. But we sort of, I think, Michelle, you may know the history of that document better than I do, but I think that was more of a just grassroots effort to reach out and connect folks and know them. Another option is, you may be familiar with Psychology Today. That website has a lot of folks who are in private practice create profiles on that website, and they include their areas of expertise in their profiles. So there is a way to search for providers using the therapy finder portion of that website, and to search for people who list sort of gender as one of their areas that they focus on clinically.
I'm going to hop in real quick. I was going to highlight that same resource. And then I know about here in Western Mass, there are a couple of programs like Trans Health, which is a clinic that just opened in Northampton, and also a program called Translate Gender, which I think isn't just based in Northampton, but I think a lot of this is grassroots, but there are places where this is the focus of their care, where there are people who have been really putting together resources. So Translate Gender is a place that has a resource page on their website that has a whole list of Western Mass resources, including kind of caregiver support groups and groups for kids, but also providers, and looking in your geographical area at similar types of programs. I know, like, obviously many of you might know of different hospitals, but the GEM program with Boston Children's, for example, or our clinic here probably has their own lists.
Thanks for giving a plug to the GEMS program, Shelby. That's another. So we're very fortunate in Massachusetts, not just to have the program that you guys are operating, at Bay State, but we have the GEMS program at Children's. There's a member of that program, Dr. Jennifer Gentile, who is in the audience today. And so she could feel free if she wishes to tell about that resource. But it's nice that there are resources. And we also have just the context of this talk. MCPAP is a place to go if you are looking for therapists, because MCPAP, is really expressly for primary care providers for any kind of mental health need. And one of the things that we do in MCPAP is really do resource and referral work to try to help people find resources, including therapists who may specialize in working with gender identity issues and trans and non-binary patients. So we have a question in the chat about other societies and cultures in terms of, we know about our culture in the United States, which, is very diverse, but we certainly have, a long way to go to embrace, the diversity of transgender and non-binary people. And so do you guys know of any other cultures that, have a less strict sort of separation between the genders and more of an inclusive sort of milieu, for people who are non-binary or transgender?
I know that I've read research about a number of places and cultures that have over time named gender as being more on a spectrum, but one that often comes to mind is this two-spirit identity, which is part of the Navajo culture and often is a really helpful term to use when people are identifying as non-binary, and maybe using the pronouns they, them, which can feel really challenging for some people to change to that, but really thinking about sort of holding some part of both or being somewhere between. I mean, in that sort of this two-spirit, it's sort of talking about a both, and sometimes people who identify as non-binary are other. But there are a number of native or sort of indigenous cultures, I think in Hawaii as well. There is a group called the Kumahina, I believe, that are also identifying as someplace off the binary. But I would be nice to know more. I know that there are quite a few.
Thanks, Shelby. There's another question actually sort of related to cross-cultural work from Ilana Schmidt. And Ilana was referencing some of the sensitivity and the challenges of framing questions about gender identity with children who come from cultures that are less accepting. And Ilana called out Pakistani and some South Asian cultures, but I'm sure that it's much. There are many cultures, including ours, where people are not going to necessarily receive these questions well. And do you have any recommendations about sensitive ways to really approach? I mean, I think you've talked about this a bit, but I wonder if there's any approaches that you have for people who are especially sensitive about these kinds of things.
I don't think there's any one way to do it because a lot of the conversations are difficult sometimes. And thinking of one family in particular who of South Asian family was a trans female, and in that way it worked a little bit to emphasize separating out the parents and the child and sort of talking to them separately and kind of seeing where the child is and then what concerns they have about potentially disclosing to the parents or the parents already the reactions the parents already have had to the child if they had tried to express themselves at home. And then spending some time talking with the family separately, just acknowledging their concerns and their views and not sort of, brushing it off. But I don't have any magical words or way to do it, to be honest, besides it is an individual approach. And it might take a little bit more time to get that family in a more supportive role for that individual. So to just be cognizant of that, as you're talking about things with the child and the parent together. And I think creating a safe environment for the individual is really key, because you want that individual to be able to express themselves, at least in some space, even if they have to continue to work on expressing it in their home life or cultural life.
Thank you so much, Michelle. So we are going to have to end. There's one more question which we don't have time to cover, but we will send it to the panel, and we will try to get back to you on that last question. But I wanted to thank the speakers so much. My colleagues at Bay State, I'm very proud that you guys did such a nice presentation, and really appreciate that. And thanks for the audience questions and for your participation. And we'll see you next month. And please take a moment to fill out the survey at the end. It's just like a flash survey, so it's not going to take more than a minute or two. So thank you so much. Bye, everybody.